Welcome to the EAU podcasts. In this episode, UROONCO BCa Chief Editor Dr. Benjamin Pradere talks to Professor Nicholas James on the BladderPath trial results he presented at ESMO 2025.
Dear friends, dear colleagues, it's my pleasure to be at ESMO 25 on UROONCO, and I have the honor to be with Professor Nick James. Thank you very much to be with us today. You have presented an amazing and very awaited last results of a trial that is, for us as urologists, potentially a game changer, or at least needs to give food for thoughts. Thank you for being with us. Can you tell us a bit more about your trial and the rationale behind it, the story on how you built this study?
Yes, thank you very much, and very pleased to be here talking to you. So the rationale is that, with the exception of flexible cystoscopy, the pathway for diagnosis and actually management, if you're going down the surgical route, hasn't really changed for a century. And that's very unusual. Yeah, mostly medicine moves much faster. And the problem with the pathway is that you have a one-size-fits-all thing where everybody with a bladder mass gets a TURBT, and the surgeon is aiming to resect all the tumor down to muscle.
Yeah.
And it's a very curious procedure because it's a biopsy, a very, very big biopsy, you'd have to say. We don't normally need that much tissue to diagnose a cancer. Yeah. It's a staging procedure, and it's a staging procedure where a lot of the time you don't get an accurate stage. Yeah, we're sitting in our MDTs afterwards, and they're saying, well, it's high-grade tumor, there's no muscle. And then you go back and you re-resect. And so that's 6 weeks delay before you even got to any sort of proper diagnosis in the worst patients.
Yeah.
And then the third thing is, if it is NMIBC, it's also the treatment. So you've got 3 procedures rolled into one. And that's just really unusual in oncological terms. So, and the important thing is that if you turn out to have muscle-invasive cancer, yes, it's a histological diagnosis. Yes, it's a stage if you do it right. But it's most definitely not a treatment. It's a very poor treatment. In fact, it may be an actively harmful treatment, because we know that a lot of the time, depending on the experience of the surgeon, 50% in some series is extravesical contrast. That's extravesical tumor that you've put there. And 5% overt urinary leak. That's morbidity, hospital stay, not very nice for the patient. So it's not a very good procedure. So the hypothesis was that if you've got patients who might be muscle invasive, then do an MRI scan and then decide what you're going to do.
What do you mean by what you're going to do there?
Right. Okay. So the first stage, we were worried about the MRI load, and I know we're going to come back and talk about that. So we said, well, if you as the surgeon are confident that this is NMIBC, if you're confident it's NMIBC, just go straight to TURBT. 97% of the time they were right. It was indeed NMIBC. They said, if you're not sure, then those are the ones we're going to randomize.
Okay.
So we registered everybody, but we only randomized the ones who the surgeon thought might be MIBC, which is about half of the total.
The radiologists were deciding if it was a risk of being MIBC for in.
No, the urologist was deciding at the flexible cystoscopy, I think this might be muscle invasive. Okay. So if they were confident it was definitely non-muscle invasive, they were almost always right. If they were not confident, we used the 5-point Likert scale, okay. Definitely sure it's the other. So the urologists were very good at spotting, small little things that were NMIBC. Where it was a bigger, nastier looking tumor, the uncertainty. We weren't asking them to say what they definitely thought it was. We just wanted to say there was uncertainty. So those patients got randomized to MRI or just standard pathway. And then you've got another level of uncertainty. What does the MRI show? So you've then got, again, a range of uncertainties. And of course, sometimes you're right, sometimes you're wrong. And what we said in the trial was what we wanted to happen in the trial, but it didn't happen, was we wanted people to do an MRI and then just do a biopsy and get on with treatment. But we said, if you want to do a TURBT, you can. And we collected the reasons why.
Okay.
And so there was a whole load of reasons why. So sometimes it was uncertainty. Sometimes it was, well, we want to debulk the tumor because they're having chemo-RT. Yeah. Oh, I happen to think you don't need to do that. But anyway,
complete your RT.
Yeah. But I don't believe you need to do that. So in my center, we don't. But other centers do. But anyway, leaving that aside. And sometimes the surgeons were saying, well, yeah, I'm happy this is muscle invasive. We're going to do a cystectomy, but I want to check the CIS. I want to check the urethra. I want to check whatever I want to check as a surgeon. And then we'll get on with the treatment. So the trial was in 3 stages. first stage was feasibility. Can we do it? And we published that a couple of years ago, and the answer was yes, you can. This was a multi-center trial. We screened 600 patients, 150 of them consented. And of the ones randomized to MRI, over 90% got the MRI in a timely fashion. So tick, we did that. The second stage, which we already published, was what does this do to time to treatment? Now, I don't know, I assume in France and elsewhere in Europe, you have the same sorts of issues. Yeah, you have a flexi one place, you might have a TURBT somewhere else. You might be then referred somewhere else for your cystectomy. Somewhere along the way, you have a resection. So the pathway intrinsically has delay built into it. So the hypothesis was that we would reduce that because you would make a better decision after the MRI. And you do indeed reduce it. So when we started the trial, NHS data showed that the typical time from, say, hematuria clinic to cystectomy was about 130 days. We were worried that when we ran the trial, we would improve it just by running the trial, and we did. So it came down to 95 days. So it got 35 days faster just by running the trial, but it got another 45 days faster if you did the MRI first. We knocked 6 weeks off the time to treatment, even though 85% of the patients ended up having a TURBT for a whole range of different reasons. And that's really important because one of the things that has generated a lot of discussion was, well, do you really want to do a cystectomy without a TURBT? And it turned out nobody did a cystectomy without doing a TURBT. Everyone had had a TURBT. So one of the potential criticisms of the trial, which I accept was inherent in the design, actually didn't happen because the urologists were actually quite conservative. I mean, probably rightly.
But maybe that's hoping there's a next step.
Yeah.
A new trial where you are forced to not do the TURBT when you're 100% sure.
Well, I think that
it might be C.
That's very interesting. So what has happened within our own hospital network is that now we're doing a lot of MRIs. It's not uniform. I can't say every time we do it, but we're doing a lot. And what we're seeing, and we see this very frequently, is that we've got the MRI. It's very clearly a T3, T4 tumor. The surgeon is doing a TURBT, but really limited one, and may not even have small biopsy, but it's done through a rigid cystoscope. So it comes up on the operation list as the same operation, but it's really not, resect everything. And also we're very happy if we got the imaging that says this is muscle invasive. We're very happy if the biopsy doesn't have any muscle in it. For example, so we are doing treatments now without any muscle in our biopsies.
So you don't need you don't look at muscle invasiveness. If you are sure on the MRI, you get it
Exactly.
So you just confirm that it's urocellular cancer.
Yeah.
And then you go
to whatever. Yeah.
Chemotherapy or neoadjuvant chemo, whatever.
Whatever. Yeah. Now, if we're not sure, and sometimes it's not a perfect test, the MRI. If we're not sure, then we will insist that we have muscle before we do anything else. So, but basically, you're doing the TURBT armed with knowledge about what you're probably dealing with, and also you know that if this is probably muscle invasive cancer, it's important you do all the steps right. It's more challenging. You need a senior urologist, someone like yourself, too. You don't need the first year resident doing it.
No,
the first year resident can do the TA tumor that is harder to mess. I'm not a surgeon, but. You know what I mean?
Yeah.
It matters who does your surgery. And so it means you can get the right person in the right theatre with the right surgeon and the right team in a timely fashion. And that's what we confirmed. You improved the time to treatment a lot. So what we now showed, and we already knew this when we published the primary paper, we were already seeing there were more recurrences in the TURBT arm of the trial than the MRI arm. And
why do you explain that?
Well, if you look at the timing of the recurrences, a lot of the recurrences are happening really early. So I think they just never got anywhere near treatment before they'd already started relapsing.
Okay.
I think is probably the explanation. But we collected 3 sets of outcomes, and we collected it, quite interesting thing. We just collected NHS digital data, and we worked out an algorithm that says if you see these things together in the NHS data, it's a recurrence. So we collected all the follow-up data without seeing a single patient.
Wow.
We did it all online. And so that in itself, I think, was quite an interesting way of doing it. And we validated in a subset that it was accurate. So basically, if you had a cystoscopy followed by a cystectomy, that was probably a recurrence. If you had a cystoscopy followed by gemcitabine cisplatinum, that was probably a metastatic recurrence, and so on. And so we did that without doing any follow-ups. We had 2-year complete follow-up on all of the patients in the trial minimum. And the hazard ratio for failure, for bladder cancer specific survival and overall survival are all less than 1. And we think that's very clearly important. But particularly, one of the criticisms we've had of the trial, and they're fair, is that, well, maybe you put the wrong patients in the wrong box. And you've labeled non-muscle invasive cancer, bladder cancer patients. They have, you've done treatment faster, but the wrong treatments. Mm-hmm. So if that were true, you'd expect that to make the outcomes worse. But actually, we definitely didn't make the outcomes worse. We know from the stats, it's extremely unlikely the outcomes are worse on the MRI arm.
Yeah.
They're almost certainly better. How much better we can debate because the numbers are not really big enough. But for bladder cancer specific survival, the p-value is 0.5. It's under 0.5. It's the same as EV Pembro preoperatively with a single scan. It's a lot cheaper. So for me, this feels like something that really, really should be implemented.
Okay, to finish and to try to summarize, I'm a urologist. Yeah. I want you to just let me know how you see how I can do it straightforward tomorrow to start to implement a new strategy for my patients.
So I think you should do what we did in the trial. So when you do a flexible cystoscopy, ask the question, is this non-muscle invasive? If you're very sure, then you need just go to TURBT. Probably in about half the cases, you'll say, well, this might be muscle invasive. It's a nastier, bigger tumor, more bleeding, whatever. Do an MRI before you do the TURBT. And you will be doing a relatively small number of MRIs because bladder cancer is not that common. Only half of them are maybe muscle invasive. So you're doing some extra MRIs, but you're essentially doing the same scan that you will, I hope, be doing for your prostate cancer patients. And certainly in the UK, we do it for all our raised PSA and MRI. So we're doing 20, 30 times as many prostate as bladder MRIs. You will find once you start doing it that most of the time you'll get very clear pictures. And it will enable you to make better decisions. It's really easy to implement because, you guys are all familiar with looking at MRIs of pelvises. You know what they look like.
Yeah.
And that's the only thing you need to change.
Okay.
But if you're talking to people like Jim Cato, who's a obviously very well-known urologist and one of the other authors on the paper, we have a number of urologists as authors. But what Jim says is that armed with the information on the scan, yes, they hit a TURBT, but I know they just need a quick limited one, and then we get on with the treatment. He confirms what I said, which is that you just make better, faster decisions.
So you faster the decision, you de-escalate a bit the surgery, try to do less surgery or less invasive surgery for these patients.
Yeah, okay, exactly. Yeah.
Okay. Professor Nick James, thank you so much for your time. Great. It was a pleasure to have you on UROONCO and hope to see you soon.
Yeah, thank you very much.
Thank you for listening to this episode of EAU Podcasts. To keep up to date with bladder cancer developments, visit our educational platform UROONCO Bladder Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.